Okay, today we will discuss about the pericarditis, right? So before starting, what is a pericarditis? But we know that the layers of the heart, how many layers has the cardiac tissue? How many layers? Three layers, right? So the epicardium, myocardium, and endocardium, right? Okay, so today we will discuss about the pericarditis. So the pericardium. So the pericarditis is basically the inflammation of pericardium. So what is a pericardium? So pericardium is the outer covering of our heart, right? So endocardium is innermost, myocardium is middle, is basically the muscles, cardiac muscles, endocardium, heart valves, like stuff, and epicardium, right? So the epicardium is also known as a visceral. Epicardium is also known as a visceral pericardium, right? So it is also known as a visceral pericardium. So can anybody tell me this layer? This is parietal pericardium. This is a high yield stuff. In between visceral pericardium and parietal pericardium. The other name of the visceral pericardium is epicardium. So in between these two layers, which fluid is running? Which fluid is running?
As the pericardial fluid.
Pericardial fluid. This is again a high yield stuff. The pericardial fluid is in between visceral pericardium. So the pericardial fluid is in between the visceral pericardium and parietal pericardium, right? So this red is fibrous pericardium. So it is outermost pericardium layer. Fibrous pericardium. Okay. Can anybody tell me where the coronary vessels are located? In which layer of the heart or which? Can anybody tell me where the coronary vessels are located? Okay. So below the epicardium. Okay. Below the epicardium or in epicardium. So this is again a high yield stuff. And the pericardial fluid is in between the visceral pericardium, which is a epicardium, visceral pericardium. Sometimes they give you the option epicardium. So don't make confuse about this. Epicardium and visceral pericardium is the same thing. Parietal pericardium, right? So I hope this makes some sense. So the inflammation of the endocardium is known as endocarditis, right? So, and most common cause of the endocarditis is a bacterial infection. Myocarditis is the inflammation of the myocardium, and the most common cause of the myocarditis is a viral infection, right? Okay. So the pericarditis is the inflammation of the pericarditis. There is a lot of classification of the pericarditis. It may be the acute, it may be the chronic. Uh, I'm making this classification only the high yield stuff related to the pericarditis. That is an important point on the USMLE point of view. I'm not going to discuss the whole pericarditis in detail, right? I'm discussing only the high yield point. Okay, so pericarditis. It may be the acute pericarditis, it may be the uremic pericarditis, and it may be the constrictive pericarditis, right? So can anybody tell me what is the nerve supply of the pericardium? Nerve supply
Phrenic
of
nerve.
Is it a phrenic
it
nerve?
is a phrenic nerve, right? Phrenic nerve. So it the pericarditis pain may refer toward which area?
Say that again, please.
Okay. So pericarditis pain may refer to the shoulder, right? And it's because of this phrenic nerve. Okay. So acute pericarditis. So the acute pericarditis is basically the inflammation. So what is the presentation of the acute pericarditis? The presentation of acute pericarditis. So the patient present with pleuritic pain. Pleuritic pain. What is a pleuritic pain? So pleuritic pain is a chest pain that is aggravated by inspiration, and relieved by
Leaning forward.
leaning forward and sitting up. And it is also aggravated by supine
Well, if you
position, leaning.
yes,
Yes,
leaning backwards.
the pleuritic chest pain is a key thing. Okay. In acute pericarditis is again high yield stuff. So on examination, on auscultation, what will you find? Friction rub, pericardial friction rub, right? So acute pericarditis, what is the most common cause of acute pericarditis? This is again a high yield point. Most common cause of acute pericarditis. Okay.
Yeah, could be due to like viral infection.
No, it is idiopathic. After idiopathic, it may be viral, right? But when you're asking
Okay.
about the most common cause of acute pericarditis, it is idiopathic, right?
Okay.
The ECG changes are the very, very high yield. Sometimes they give you the ECG changes on the clinical vignette, right?
Okay.
Okay, I am going to show you the ECG. Okay, so this is a typical ECG of acute pericarditis. So the acute pericarditis ECG changes are wide spread ST elevation, right?
Yes.
And diffuse,
PR depression.
widespread or diffuse. Widespread or diffuse, PR, depression. Okay, this ECG is again a high yield. Okay, so these are the ST segment elevation in lead 1, right? So these are ST segment elevation, right? These are, so this ST segment elevation does not anatomical pattern like if anatomical pattern inferior wall, lateral wall, right? Interior wall. This is a random, right? Widespread ST segment elevation and PR depression. And the most common cause is idiopathic. So it is also associated acute pericarditis is increased risk of some autoimmune disorders like SLE and rheumatoid arthritis. Sometimes they give you the long clinical vignette on the SLE and rheumatoid arthritis, right? And you have to identify the cause of this pericarditis, and this is autoimmune. Okay, how will you treat the acute pericarditis? Okay, how will you treat the acute pericarditis?
We can use like NSAIDs, glucocorticoids,
NSAID,
glucocorticoids.
Colchicine. When we use NSAID, first we use NSAID and colchicine. If there is a contraindication of the NSAID, which are the contraindication of the NSAID?
If the person has like renal disease.
Yes. So you avoid if they give you the renal disease, the gastric problem, right? So you have to
Yes.
avoid the NSAID and give the patient corticosteroids, right?
Yes.
You have to identify the things they given on the. So try to practice the ECG of acute pericarditis. This is again a very high yield ECG. So we discussed two ECGs in this session. One ECG is the acute pericarditis and another ECG of the cardiac tamponade, right? Okay. So what is the difference between uremic pericarditis and uremic pericarditis and post-MI pericarditis? What is the main difference? Uremic pericarditis. So the uremic pericarditis patient has a kidney problem. So the clinical vignette shows increased blood urea nitrogen, increased creatinine, right? They also history of long-standing diabetes, hypertension, this kind of stuff. But the key thing is increased creatinine and blood urine. What about the ECG changes in the uremic pericarditis? Is there ST segment elevation present in uremic pericarditis or not? Hello?
I'm not sure.
Can anybody tell me? What about the ECG changes in uremic pericarditis?
It's the same. Wide ST segment elevation will be or depression.
No, this is
No.
again a high yield point. So the post-MI pericarditis show the ST segment elevation. But when they are give you in the clinical vignette, increased blood urea nitrogen, increased creatinine. So on ECG, there is no such finding like diffuse or widespread ST segment elevation or PR depression, right? Does it make some sense? Uremic pericarditis.
Okay.
There is no such typical ECG changes in uremic pericarditis. So how will you treat the uremic pericarditis? This is again a high yield point. How will you treat the uremic pericarditis? So dialysis.
Dialysis.
So dialysis, right? So this kind of thing you have to extract these kind of the information on the clinical vignette. Look on the lab values, look on the ECG. Even they give you the ECG on the uremic pericarditis to confuse you, right? What about the ECG? May be normal in the uremic pericarditis, right? Okay. It makes some sense.
Yes.
Okay. So uremic pericarditis. So what is a Kussmaul sign? It is a paradoxical increase in JVP on inspiration. When we inhale, so what happens? Intrathoracic pressure will be decreased, right? So when intrathoracic pressure is decreased, it will lead to increased venous return, right? So when there is increased venous return, so it will lead to the decreased JVP. So this is normally what happens. So what happened in the Kussmaul sign? So impaired right ventricle filling. Impaired right ventricle in Kussmaul sign. Impaired right ventricle filling. So the right ventricle is, if right ventricle is not filled, so what happens? So blood is build up, pooling on the blood take place, and it will accumulate on the vena cava, and it will lead to the increased JVP, right? So Kussmaul sign is present in which conditions? These are again high yield stuff. The Kussmaul sign present in constrictive pericarditis, any other condition? Constrictive pericarditis, restrictive cardiomyopathy. Okay, restrictive cardiomyopathy, constrictive pericarditis, right heart failure, and many more conditions. It may also present in pulmonary embolism. Okay, so you have to identify the Kussmaul sign on the clinical vignette, and they ask about the causes of the Kussmaul sign, right? So constrictive pericarditis is again a high yield stuff. Constrictive pericarditis. Okay, so can anybody tell me the constrictive pericarditis? What is the most common cause of constrictive pericarditis in USA? In USA, most common cause of constrictive pericarditis in USA.
Idiopathic?
Idiopathic. Idiopathic or viral. What about developing countries?
TB?
TB. Like if they give you this kind of stuff, the patient is immigrant from the India, China, Pakistan, Sri Lanka. So these kind. So this is the key thing about the cause, and it will be tuberculosis, right?
Okay.
Okay. So USA, so its cause will be idiopathic, and if it is developing country, so it is TB. Okay. So constrictive pericarditis is basically due to the chronic inflammation of the pericardium. The chronic inflammation lead to chronic inflammation. What is a consequence of the chronic inflammation? Fibrosis plus negative calcification. So in this way, the pericardium becomes stiff. So constrictive pericarditis lead to the diastolic problem. So diastolic problem is mean decrease ventricular filling. So ventricle is unable to relax because of different pericardium. The different pericardium due to the chronic inflammation, which lead to the fibrosis and the calcification of this pericardium. So this fibrosis limit the expansion of ventricle during the diastole. So constrictive pericarditis lead to the diastolic problem. Okay, so we already discussed about the most common cause. So if there is a impaired ventricular filling, so what will be the decrease? Decrease and diastolic volume. So if there is decrease in diastolic volume, what will happen to the cardiac output? Increase or decrease?
Decrease.
So cardiac output will decrease. Okay. So the patient present with dyspnea. Why? Because the decreased cardiac output, and patient may present with GVD. Why JVD? Jugular venous distension.
It's because of the compensation. So the heart has to relax as the ventricles are filling, but that is not the case because of the effect of the pericarditis.
Okay. Okay. So the causes of the constrictive pericarditis is important. Give me a minute. I am going to change the slide. Pericarditis. My screen is again visible or not?
Not yet.
Not yet. Okay. Okay. Still not visible?
Not yet.
Okay. So pericardial effusion. So pericardial effusion is basically the accumulation of the fluid in between which layers of the pericardium?
The viscera and the parietal.
In?
The viscera and parietal.
Okay. So the pericardial effusion may lead to the cardiac tamponade, right? So the cardiac tamponade. So the pericardial effusion lead to the cardiac tamponade, right? So the main factor that lead to the cardiac tamponade due to the pericardial effusion is a rate of accumulation of the pericardial effusion, right? If there is a blunt trauma and there is a little, let's suppose, normally the pericardial fluid is 50 ml. So like if there is a blunt trauma takes place to the chest and the fluid is accumulated 150 ml in pericardial space. So it will lead to the cardiac tamponade. Some chronic condition like SLE, rheumatoid arthritis, they also lead to the pericarditis, and pericarditis lead to pericardial effusion. So it may be cancer lead to the pericardial effusion, pericarditis. it is 1 liter. So due to the cancer. But this 1 liter pericardial effusion does not lead to the cardiac tamponade, because the most important thing is the rate of the fluid accumulation. Because here is the rate of fluid accumulation is quick in blunt trauma, right? But in the cancer that lead to the metastasis, lead to the pericarditis and pericardial effusion, does not lead to the cardiac tamponade. Sometimes they give you the what is the important stuff that lead for the development of the cardiac tamponade. So it is a rate of accumulation of pericardial fluid. This is again a high yield stuff. Okay, can anybody tell me what is the back striae? Back striae.
Elevated jugular venous pressure.
Okay. Elevated jugular venous pressure.
Then decrease BP and
Decrease heart sound. Sometimes muffled heart sound. Sometimes mention the distant heart sound. Right? So clinical when it sometimes you say the decrease heart sound. Sometimes say you the muffled heart sound. Right? So the
Yes.
back striae, you found a lot of question on the back striae.
yeah.
Back striae. Okay. So the ECG finding in the cardiac tamponade, again the high yield. The ECG finding in the cardiac tamponade is again high yield. So the what is the ECG finding in the cardiac tamponade? Main ECG finding. Their main ECG finding. Electrical
Alternates.
electrical alternate. So they give you the ECG of the electrical alternate. You have to identify electrical alternates. There is a variation in amplitude of the QRS complex. So here is the QRS complex is decrease. Here is increase, increase, decrease. This variation in the QRS complex is electrical alternate. So sometimes they give you this kind of the scenario and they ask about what is the cause of the electrical alternate. So what is the cause of the electrical alternate? So it is a swinging movement. Swinging movement, very high yield. Swinging movement of heart.
Okay. Swinging movement.
Because heart is knotting on the fluid, pericardial fluid. There is a massive amount of the fluid in the pericardial space, right?
Yes.
Mhm.
Okay, so this is the cause, swinging movement of heart in the pericardial effusion. Okay, another question. So, what is a pulsus paradoxus? Pulsus paradoxus.
During inspiration,
Yep.
there is a more than 10 millimeter of mercury fall in BP.
Okay, the systolic blood pressure will decrease more than systolic blood pressure,
Yes.
more than during inhalation, right?
Yes.
So,
Yes.
what are the causes of the pulsus paradoxus? So, I think is a mnemonic is P cot. Pulsus paradoxus mnemonic is P cot. So, P for pericarditis. C for
Group.
proof. O for
Obstructive sleep apnea,
obstructive sleep apnea. A for
asthma,
asthma. And T for
cardiac tamponade.
tamponade. So this is again a high yield stuff. The causes of the pulses, paradoxes. So, pericardial effusion lead to the cardiac tamponade, right? The cardiac tamponade is an emergency, right? Cardiac tamponade is emergency. So back triad, we already discussed the back triad. So what are the causes of the main high yield causes of the cardiac tamponade?
Wait,
High
say that
yield.
again, please.
What are the causes of the cardiac tamponade? So it is maybe a stab wound to the stab wound. It may be left
Aortic
ventricle.
dissection.
Yes, left pre-wall rupture, right?
Yes.
Post-MI.
Yes.
So rapid accumulation of the blood in the pericardial space, right? So it will lead to the cardiac tamponade, right? So again, another high yield stuff. So in pericarditis, the first line investigation is ECG, right? Next investigation is echo. Echo will show about pericardial effusion. Best investigation is echocardiography, right?
Okay.
Okay. So one more high yield thing related to the pericarditis is a cocaine. Cocaine is also associated with pericarditis. So how the clinical vignette they show you? So a young patient, let's suppose 22-year female or male, comes in emergency with chest pain. So he comes from party. Is my screen is visible or not?
Not yet.
Okay. So the cocaine is associated with pericarditis, right? So young patient come with emergency department with chest pain. ECG show diffuse ST elevation and PR depression. So sometimes they ask about what are the cause of cocaine, right? So sometimes they ask about the diagnosis. So the diagnosis is the pericarditis, right? Okay. Still my screen is visible or not?
Yes.
Okay, so these are some high yield points related to pericarditis. So the post-infarction fibrinous pericarditis is a post-MI pericarditis, right? So it is if less than 1 week after the MI, and it is due to the inflammatory process. And the treatment is aspirin or early coronary reperfusion therapy. Sometimes they give you the aspirin, sometimes they ask about the early coronary reperfusion therapy. So what is the Dressler syndrome? So Dressler syndrome is also fibrinous pericarditis, and it is autoimmune. It is due to antibody mediated, and it is 2 to 6 weeks, 2 to 6 weeks usually after the MI, or sometimes they give you the 1 week, and usually it is 2 to 6 weeks after the MI. And what is the treatment of Dressler syndrome is NSAID or aspirin. Okay, these are the key summary of the some high yield point. So the restrictive pericarditis, pulsus paradoxus is absent. Kussmaul sign is present, right? Constrictive pericarditis, pulsus paradoxus absent. Kussmaul sign is present. Cardiac tamponade, pulsus paradoxus. So it is mainly. So pulsus paradoxus may present in the constrictive pericarditis, but is rare finding, right? Cardiac tamponade, pulsus paradoxus present, and the electrical alternance. This is the high yield that is present in the cardiac tamponade. So what is the difference between restrictive cardiomyopathy and constrictive pericarditis? Can anybody tell me? Restrictive cardiomyopathy.
It affects the muscles also in the restrictive cardiomyopathy, but only the pericardium is affected in constrictive
Yes, absolutely right. So restrictive pericarditis is also lead to the diastolic problem. But the pathology in the myocardium, in restrictive cardiomyopathy, but in constrictive pericarditis, the pathology in pericardium, right? So the chronic
Yes.
inflammation, fibrosis, right? But the constrictive pericarditis also impair ventricular filling, right?
Yes.
Okay.
Right.
So the pathogen associated with purulent pericarditis. This is again the high yield stuff. So the pericardial effusion in purulent pericarditis is turbid. And it is predominant in neutrophils. So most common pathogen is associated with purulent pericarditis is Staph aureus, right? Staph aureus. So Staph aureus is mainly from the skin, entry from the skin. It may be associated with pneumonia. And which organism? If it is due to the pneumonia, so which organism is? Staph nemo. Staph nemo. It may be associated with fungus, mainly Candida albicans. Candida albicans in patients who are immunocompromised. Right?
We can't hear you, Doc.
Can anybody hear me? Hello?
Yes, you're audible. Yes, you're audible.
Okay.
Hello? You're audible.
No.
Does purulent pericarditis make some sense? Hello? Hello? Okay. Is my screen is again visible or not?
It is not.
Okay, I am talking about the purulent pericarditis. So the purulent pericarditis is associated with some high yield microorganisms, right? The purulent pericarditis mean turbid pericardial fluid, increase neutrophil on pericardial fluid, right?
Yes.
So Its most common organism is Staph aureus due to skin infections, and it is due to Staph pneumo. In case of pneumonia, purulent pericarditis may also occur due to the candida. Candida is fungus in particularly immunocompromised patients. Right?
Yes.
Please.
Okay. So why we avoid NSAID in the post or pre-infection fibrinous pericarditis, right? So NSAIDs increase risk of pre-wall rupture, right? So that's why NSAID are avoided in the first 7 days of the post myocardial infarction, right?
So, so the NSAID can cause the free wall rupture?
Increase the risk. I'm not saying
Increase the
increase the
risk.
risk.
Okay.
Increase the risk of the
Oh.
free wall ruptures. That's why we try to avoid the NSAID. And we also,
Okay.
so aspirin are early coronary reperfusion therapy, right? So they
Okay.
decrease the risk of fibrinous or post MI fibrinous pericarditis.